Thank you, Sister Ziada. We appreciate your words, and thank you to all of the presenters here this morning, this afternoon, wherever you find yourself. I have to say I'm humbled by the work that we have heard presented today, and certainly there has been a lot of discussion, a lot of questions in both the chat and the Q&A. I certainly will probably not be using the questions that I had prepared for this because there are so many great questions in the chat. I recognize we only have 10 minutes left. I know some people have already had to start dropping off. I want to let everyone know, you may have seen in the chat that we intend to make this recording available on a number of sites, including the HERD Implementation Science YouTube channel. It will be available on the Advancing MNCH website, and we will also be sending out each of the panelists an email that shares how and where you can get follow-up. I'm struck that certainly by the activity that's gone on in both the Q&A and the chat, and I apologize, I don't know if I introduced myself. I'm Dilys Walker, also from the University of California, San Francisco. And before we launch into the brief Q&A, I also just want to thank all of the organizers, the partnership that is involved not only in producing this webinar, but in this movement, I think is a lot of what drives its power. And I'd like to really thank USAID for their support and leadership in this effort. Even though it began 10 years ago with some important work, it is still clearly very early, and we have a lot still more to do, particularly around this area of interventions and how to actually make birth safe, kind, and respectful for everyone. So I'm going to ask the panelists that we have, Dr. Chibugu Okoli, who you've heard from, Dr. Nadia Diamond-Smith, Ms. Lucy Chigwenembe, and Dr. Patience Afulane to put their cameras on because we're going to do a quick Q&A with those. And I think what I'm going to start it with is something that one of the presenters alluded to early on. You know, this is a movement that began more than 10 years ago. It has had lots of momentum. There are many people working on it. And something that I have been seeing, and I'm sure many of you have also, is that the COVID pandemic that has hit all corners of the globe is really, you know, many people were thinking it would impact facility-based delivery and antenatal care. And we're finding that that is pretty well maintained, but what we are seeing is many more reports of mistreatment and abuse and problems with the experience of that care. Maybe I'll just ask, I'll start with Lucy Chigwenembe and see if you have any thoughts that you can share about whether you think that the COVID pandemic has caused this lots of movement backwards rather than forwards.
Thank you so much. Like for the case of Malawi, like when we were hit with the COVID-19, at first we saw like a drop in the antenatal care attendees. Of course, it was that women were afraid to get the coronavirus from the health workers, but also the health workers themselves, they were also afraid. So when the ministry noted that, like they sensitized all and also encouraged mothers to continue assessing the antenatal care, because like we thought and we said like maybe the effects would be so grave than the COVID itself if people are not attending the antenatal care. So we saw a change, but still women were still not comfortable. And even now after the antenatal care, when they come to the clinic, let's say like to get any injection, they're afraid of being given the COVID-19 vaccine. So like we find that like in the labor wards, people are afraid of getting the oxytocin after birth and all those. So like those are some of the effects that we are seeing and facing in Malawi. But for the antenatal care, we sensitize the women, and then we have, of course, seen the rise, but at first there was a drop of attending antenatal care in our facilities.
Thank you very much, Lucy. Appreciate that. I think it's there has been lots and lots of interest in discussing interventions. There's been discussions in how can we move this pandemic forward. One question in the Q&A that jumped out at me was from Mary Ellen Stanton that sort of said it best, saying that a big question that hasn't been directly tested, and that is focusing on grievances, mistreatment more effective than focusing on respectful care to promote a more positive experience of care over time? And I think this also gets at a number of questions in the Q&A about the language and the terminology. And I'm going to throw that one out there. I'm going to first ask Patience what you think about, you've really looked into this, and then I'll turn to Nadia and see if either of them this terminologies and framings. This is probably a much longer conversation, but I'll let you get started.
Yeah, I mean, there is no simple answer to that, right? I think Emma brought it up in the chat that we needed certain terminology initially to sort of highlight the urgency of the problem, and using terminology like disrespect and abuse, obstetric violence, sort of highlighted the urgency of the problem. But we also know that it's not in all spaces that we can start off with that language. And so I think that use of the terminology is more of something we should be thinking about in specific context to realize which language do we need to use in this context to gain entry. So sometimes you might want to gain entry with more subtle language, like talking about poor quality care and getting people who all recognize that quality of care is important before you begin to highlight that poor quality care also includes respectful maternity care. And we don't have respectful maternity care, and we have women experiencing disrespect and abuse. And so I would say it's not striving to have the same language. I think the terminology we use will differ depending on the context. And for us working in this space, being cautious about which language will gain us entry. And then once we gain entry into certain spaces, then thinking about what language will highlight the urgency of the problem and drive people to act.
Thank you, Patience. I knew you'd be able to tackle that one. Nadia, how about you? Anything to add?
I mean, I agree with what Patience said and think that that's, you know, the important way to start this conversation. And I think just to add on to that, just making sure that the decisions about what language to be using in a certain setting or context are reflective of that community or population, and making sure they're sort of not being imposed by funders or some type of outside force, because I think that there's, you know, who's deciding what language to be used at a different time is something that we need to think about carefully.
Thanks, Nadia. I'm going to turn this to Dr. Chibugo Okoli. I noticed there were a number of questions in the chat that were around this issue of the community voice and community advocacy, and how do you sort of promote, support the community and recognizing their rights and driving some of that demand. Do you have any thoughts on that for us?
Okay, thank you, Dilys. I saw those questions. And you know, the community voice is also very, very important in the arena of RMC. And there are various ways you can do that. And one of the ways is actually taking out time and working together with the community stakeholders to actually raise their awareness, build their capacity in terms of how they can actually ask for their rights. Another way to do this is as also part of the quality of care work that you do with primary healthcare facilities. And I talk about primary healthcare facilities because that's the one that is nearer the community and located within their communities. One of the ways is actually to ensure that they're engaged or part of memberships of quality improvement teams at the facility level. And in that way, the ministry or the partner that is actually supporting the ministry can use that means to also build their capacity in terms of their input and the way they take things forward on behalf of the people that they are representing in those quality improvement team meetings, which actually happen monthly when you actually set them up. And of course, the issue of also from time to time going out there and also asking the women their perspective, because women are also part of the community as well. And who better place to actually go out there and ask the question. There was a very good presentation on community voices. I've forgotten one of my colleagues that did that. And I'm sure that participants would really like to review that and see ways that you can include community voices. Thank you, Dennis.
Thank you very much. And I'm just being cognizant of the time. I just want to reiterate that we will make this recording available in multiple sources. And if you signed up for the webinar, you will receive it, bit and link to some other resources. We will look to find other ways to continue this engagement and continue this dialogue. I think partnership and collaboration is going to be our fastest way to the end point. And for those of you who can hang on, I'm going to end this with one last question that I was going to ask first, and we'll see if the panelists prepared for it, because it will take that very minimal time. You have 5 words or less. In 5 words or less, what is the most critical, core element, important mechanism that you think will drive sustainable change? You have 5 words. Our time is up, so 5 words. We'll start with patience.
Okay. I would say we need to reduce burnout, motivate providers, and hold them accountable.
Thank you. Good. Well done, Patience. I like that. How about you, Dr. Chibugo Okoli?
Okay, I would say engagement and commitment from key stakeholders to work on this. Yeah.
Thank you. And Lucy Chigwenembe?
Thank you. For me, for sustainable change, we will rely on self-motivation, awareness, and accountability on clients' dignity. Thank you.
And Nadia, what do you think?
Well, I was going to say engaging women in the process from the beginning. That might be more than 5 words, but keeping it woman-centered when we're making things.
Women-centered, keeping women in the center when we're women-centered. I like that. I love it. I have really appreciated this opportunity I've had to work with HERD and to work with all of you. And again, we will be in touch, and thank you very much for joining us, and thank you for everyone's involvement, you participants as well. I'll leave you there. Until the next time. I believe what I was supposed to mention, I know you're all leaving, that we have 2 more webinars coming up, 2 in June. One will be around evaluation, and one will be on the Advancing Postpartum Hemorrhage Care program that we have. So please stay tuned and you will get information on those. Thanks very much. Bye-bye.